Go. Okay. Hello. I guess we're planning to use this on both our podcasts. So should I say my thing? Anyway, hi, I'm Joan. I am the host of the Other Human in the Room podcast. Who are you?
I'm Deb, and I am the host of Move with Deb, the podcast.
Hey, look at us. And Deb, you've been on my podcast before talking about pain. And one of the concepts specifically that I learned from you, interestingly, as I am a physician, but I learned the concept of nocebo from you, which is wonderful. The med school didn't teach me. Then I heard other conversations you've had with other coaches, sort of expanding on it more and really reflecting on my medical training and how I was taught to speak about treatments and manage expectations in ways that now I'm getting curious about. So that's why I was like, can we have this conversation? Basically, I just want to process this and like discuss it, you know?
I love that idea. And also, as a not doctor
Mhm.
and a not medical provider, I mean, I was trained as a body worker and I did restorative exercise. And actually, in in that process, I had a lot of experiences of nocebo, which was fascinating. So I just think like in any place where there's like an expert or a learning or anything that's regarding the body in particular,
Yeah.
we're going to have experiences of nocebo and placebo. And I think we only sometimes think about placebo in relationship to pharmaceuticals, but that's not really the meaning. It's like how the meaning is applied.
Mm.
So I think it would be fun. Let's have this conversation. Let's help people be better at their jobs.
That would be great. And like, it's easier when you understand the concept. That's what's, you know what I mean? Sometimes we think like, oh, if we, in order to get better of our jobs, we have to be more precise or blah, blah. But like, honestly, some of these concepts have been very freeing. Sometimes I've had to be more thoughtful of how I speak about things, but honestly, being more thoughtful feels better and then allows for better connection. So maybe as a start, do you want to, what's your definition for placebo, nocebo
Mm.
yourself?
Um, so yeah, I'm gonna tell on myself, and I was originally gonna go kind of like go back and look it up so I could be have a concise way to describe this. And I love your face is like,
I'm
we
like,
don't
meh,
care about we don't care about being precise.
no.
So my understand I'm gonna this is how I coach anyway. So I'm going to explain it in a way that makes sense to me, like my mind and my body,
Yeah.
which may or may not match the like official dictionary version. But a nocebo is this kind of negative belief about your body, whether you're dealing with like a healing process or an injury or some kind of recovery, or even just like what people are told about their longevity or their chances for health. Like, so it's not even in a, inside of a process, but a nocebo is basically just a negative viewpoint or belief that is being given to you. Or I like to sometimes think, in the way that I teach and work with people, I think about like inputs into the brain and into the nervous system. So it's like an input, but it's a negative one. And
Mm-hmm.
then I just had this vision of like a ping pong, like not a ping pong, but like a uh uh
Pinball.
pinball. Thank you. I was like, Joan's gonna know the word, and I'm
We did it.
doing that mind meldy thing. So it's like a pinball game, then just like bopping around inside of you. And so every time you feel something, you're bringing in that negative belief and thought and expectation.
Yeah.
And then that creates your embodied experience. And there are really cool studies about nocebo and placebo. And so placebo is the opposite. It's like how we create something like positive and healing through belief. So it's not the substance, It is the belief part of the embodied experience. That's why they have to test medication to see that it works better than a placebo, right? And then there's all kind of cool studies about like what size of the pill and what price of the pill and all the things like about, there's even when people take medications, like the thoughts you're thinking when you're taking the medication, how you're thinking about this changes its efficacy. So
Wow.
it's our mind, our body, our belief. Like this is the part where I'm like, belief is a medical or a physiological experience. And so doctors or medical providers really need to understand that. Like
Yes.
you have to understand what is the belief that it's like, okay, you're delivering something, right? Like you're a provider and you're delivering a medication or a treatment. Belief is part of the treatment
Yes.
protocol. And that, wow, I kind of knew exactly what I wanted to say about that. And I didn't have to look that up at all.
No,
I feel
but
very passionate about this.
well, I wrote down belief, the medical intervention.
Mhm.
And that's it. And it's really interesting because I think about how I was explicitly, but also sort of implicitly taught about placebo. I swear, maybe, okay, so say one of my professors that taught me and he taught placebo when I wasn't listening, maybe was taught it, but I don't remember. Like, anyway, like the notion, placebo was not really even given any, like, I don't remember it being a focus. It was always like, oh, it's just placebo effect. And like the more I think about that, I'm like, we missed like how incredible our minds are in impacting, or like we missed like this core way that our brains and our perceptions then impact our perceptions, like our physical experience. And like we missed all of that because it's like, oh, like I hear that a lot, like, oh, so that one was just placebo effect, or like, I hear it a lot from learners. And so I'm always like being like, placebo effect is the best. But it's like, I feel like I didn't do anything in there with the patient. I just listened to them and then they like said they felt better, but it's like just placebo effect. Like it's like put down in this way. And like that really bums me out now.
Absolutely. But I love that you're bummed out, right? So, because we can, right? Awareness precedes change,
Yes.
right?
Yeah.
So, we can even, the experience, like what you can reflect back to those learners are like actually sitting, maybe touching somebody gently, like relating to them, making eye contact, like listening deeply as if you're a person who cares about what they're talking about. Like those are, when we think about like polyvagal theory, when we think about how like safe embodiment, like how the relationship of the nervous system and our social engagement system, like those are part of our physiology. So they didn't do nothing. They did actually a whole series of very important actions.
Mhm.
And I keep running into, because I work with a lot of folks who are, kind of live at the intersections of different marginalizations. Oftentimes, the healthcare system is not very caring. And so people are experiencing a lack of care.
Mhm.
And it's like, why do we think that listening to people is not also therapeutic? If I find that sad
Yes.
and shocking, but you're an educator, so you could be like, no, it wasn't placebo. This is what you did.
Uh,
Do. And you like tell them all the ways that you helped somebody feel differently. And then maybe also be like, and then on the flip side, these are all the ways we increase a sense of danger, fear, overwhelm, like a belief that they can't get better, all the things, like the ways that you deliver health information
mhm.
can be done either way, really, or somewhere in the middle.
Yeah. Like some of the examples from this video that Deb sent me a while ago that I watched, it had some like interesting examples of like, well, things like the level of trust or mistrust that this person has probably in the healthcare system in general, is specifically this clinician, that will impact if they experience like negative side effects versus benefit. There was a study where they had like they would either tell the patient or the clinician that at some point, like a say a morphine infusion would be stopped, and then it wasn't stopped, was my understanding. But then no matter if it was the clinician or the patient that was told that information, the patient would experience like a dip in their pain control. Like literally the pain medicine was still dripping through their system, but they
Mhm.
were aware that a dip could happen.
Mhm.
I may be misquoting that study, but like that idea of like expectations are beliefs that then translate into our experiences as humans. And so I was just really thinking about how often we feel compelled or trained or often kind of threatened that we have to really manage people's expectations, often to say avoid medical legal stuff. We have to be like the infomercials for the drug
Yes.
company and be like blah 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 anal leakage death like you
Yes. Be
know?
the black box on
Yes.
the, yeah, on the thing.
And I see some of my colleagues like really intensely feeling like I have to make sure I warn them. And you like you sense almost the intensity. Often it's because we've been trained that way and we feel like this is how we perform well. And this is also how we manage not getting sued. Like there's sort of intense things happening from the clinician perspective,
Sure.
which so I obviously have a lot of empathy for that. And the tragedy is not only is that experience really horrendous for the clinician to always be like, I'm going to get sued. I have to like warn everyone of side effects, but also to understand that that has an impact on the likelihood that the patient will experience side effects.
Yeah, absolutely. And and the side effect, right, comes from the expectation
Yes.
and not necessarily the medication or the therapeutic treatment. And it's hard, like people are probably absolutely going to want to push back on that, and sometimes the answer is we don't know.
Hmm.
Sometimes we don't know what
Yep.
helps people
Yep.
feel better
Hmm.
or feel worse, but at the very least don't make it worse.
Do our best. And I think that was
Yeah.
something that came up like, so how do we balance like informed consent, which is like a tenet, something we're trained
Yep.
in, versus like the do no harm
Mhm.
concept, which now it's like, oh, some ways I may be doing informed consent could literally be increasing the risk of harm to patients. And just recognizing there's something to navigate there. But then
Mhm.
for me, um, I always love a harm reduction approach anyway.
Yep.
So it's like, we're not going to get this right. What does this even look like? Who knows? Obviously, the way we were trained was not the pinnacle. So let's keep going, keep
I want to,
experimenting.
yeah, and I want to bring it back to kind of like the role of the patriarchy and
Mhm.
the white coat thing, and like the
Yeah.
kind of the ownership of both bodies in the room that like
Yes.
medicine has really kind of taught people to have.
Yes.
But in some ways, that assurance is part of placebo, right? Like it's so fascinating. It can be one way or another, right? I had a very terrible appointment with a head of a sports osteo program, who had previously done surgery on me years ago. And I went to see him for some pain I was having. And I got like a whole heaping load of nocebo, including like x-rays and scans that I did not request. Like what I wanted to have was a conversation. What I ended up getting was a bunch of imaging done that I didn't even really understand what was happening, because that all happened before the appointment and even before the initial conversation. Which I understand, like saving time or whatever, it makes sense. But like, there were a lot of findings. Then they just sat me down and told me their findings based on the images without talking to me
Mm.
and hearing my story, hearing what I was dealing with in an acute way. And then basically he was like, well, you have osteoarthritis and it's going to get worse and worse every year. And you're in pain now. And it's like, literally, it's just like, it's only going to get worse. And I was like, haha, you don't know who you're talking to, because I actually am deeply understand pain. And like, it was this very when I looked at the findings, I was just like, I would not read that. I just wouldn't read that x-ray in the same way. And
Mhm.
also, like, you didn't ask me anything about my life or my experience. And I was like, I think what I actually got mad, I got really mad. I
Mhm.
yelled at some people, yelled at his assistant. And what happened was because I was sitting there imagining what just like a person who didn't understand like neuroscience and pain would be experiencing and how much fear I would be like going through, basically being told as a like 52-year-old fat person, like your pain is only going to get worse and this is why.
Yep.
And I
You're
was
doomed.
just like, and I'm doomed. And I was just like, what I ended up, the experience I ended up having to create for myself was I got some fluid removed from my knee. I got an injection. And then I was just like, I'm going to go do my work on my own. My knee feels fine. I'm squatting and I'm doing all my knee things. And it's been over a year. And like his dire prediction for me, which he delivered in this very casual kind of like, wasn't like a haha kind of way, but like he was just trying to be like, well, this is just how it is. And I was just like, that's not very helpful. And
No.
yeah, so I got mad thinking about like what is somebody else's experience of that because I knew really differently what is possible for people. And so, how do you teach somebody what they don't know?
Mm.
But I would think I was shocked because I was like, aren't you a I was like, aren't you a doctor and like a
I
surgeon?
know.
Aren't you, don't you know that you shouldn't be telling people things that sound like you're doomed?
No. In fact, so I will like I think I mean there's diversity in how people are taught. That's just, depending on your school. I think some I do think though a strong thing, often tied to medical legal, often tied to like we're supposed to give a prognosis.
Mhm,
Um and there are times where prognosis is really useful. Like if, someone's got cancer from head to toe, but even then we're learning that like there's the say the cancer example, like the old way that now is like it's like a cliche, someone will say in a movie or something like they gave my grandma 3 weeks to live and she lived for 3 years, right? And it's always like haha, fortune teller doctor, you got it wrong, like the weatherman. It's like that kind of
yes,
phenomenon.
yes.
um and so specifically in the palliative care world, I see where they're saying, listen, based on not just like these findings on a scan, but like how like I do an assessment on how you are functioning. I do an like I
Mhm,
listen to your how it's going, how your body's been responding. Like you kind of look at the whole picture over time.
mhm,
And then you say something like typically someone who has this level of disease and these kinds of factors
mhm.
will live for a few short week no, a few weeks to some short months. Like I've heard this kind of
Mhm.
language.
Yeah.
Sorry if this is like a heavy topic, but it's one
Oh,
area of
it's a good one.
medicine where it's one of the places we would potentially have the most concrete prognoses actually.
Yeah.
And the movement is to be less concrete. And
Mhm,
so I just love and want to invite the rest of medicine to consider. I think surgeons, it's a very fascinating thing that, is not, so I am not a surgeon. And so I would be curious with someone who's like been trained in surgical culture. It's like a lot about like performance and certainty and outcomes in a way that
mhm,
must not be healthy to internalize, because I know how it is for me as a primary care clinician where the outcomes are fuzzier, but still I feel like it's my fault if someone's diabetes isn't managed, or like it's like
mhm,
all of that, like you were saying, ownership over everyone, so oppressive, so rooted in these like colonial patriarchal ways where it's
yeah.
like it doesn't serve the patient and it also doesn't serve the clinician,
Mhm,
you know? And so it just thought I just put that together, like, listen, there's places in medicine where we're already doing this. And so like,
yeah.
what if your surgeon had said, when people have this level of arthritis, plus what you're experiencing, because I've listened to your story, I would imagine well, honestly, I don't even know why you would need to give a prognosis, but say you did, maybe they were like, say you asked, you're like, what could happen? Probably what I'd say, honestly, if you were my patient, is like, I have seen a range of things. I've seen some people where, say, they do some physical therapy, they do some work about the pain, and then they recover from this. I've seen other people where the pain doesn't fully, like, I might give a range,
Mhm.
which
Yeah.
then I wonder if that's like harm reduction. Like, you're still letting them know about the possibilities, which covers
Mhm.
you, but you give them the range. And I probably would speak to how the more that you believe that your pain is there to protect you, the more you have those sorts of belief systems in pain, like
Mhm.
that changes your experience in pain. Like, depending on how open the patient is, I might have
Yeah.
conversations like that, which then also shifts my
Mhm.
belief work with them, I guess you could
Yeah.
say.
A lot of like,
Yeah.
I know we probably talked about this the last time, but like so much of work on chronic pain is belief work,
Hmm.
and then like changing the experience of of the belief around the sensory experience. So it's like if you don't have a framework that doesn't say like this scan equals this pain, like it's very hard to believe something different than
Yeah.
what the prevailing messages are.
Yeah.
And I think doctors have such an opportunity to be able to say, hey, you know what, we are learning new things about pain
Hmm.
all the time. And what we're really seeing is pain is not necessarily like you know, it's not correlative,
Hmm.
right? Like it's not causative, right? Is that the word? I'm not even right? It's not causing
I guess
this,
causative
right?
is
It's
correct.
not
Yeah.
causative, but it's correlated, right?
Yeah.
Like we can talk about like there's like even multiple parts to the treatment, right? Which is
Hmm.
like, and then also the provider, I think the first part of a provider's work is to hold the belief that um like that their client, that their patient could feel better,
Yeah.
and sometimes in ways that like are not just like take this pill, do this thing that equals getting better, feeling better,
Mm.
but just even sitting down and the conversation is part of the treatment. So,
Mm.
right, just as you said, like that was tossed away is like, well, that was just placebo. And I'm just like, no, that's part of
Wait.
no, that's
That's
part
the
of the
goal.
treatment. Don't throw out maybe the most important part of
Yeah.
the treatment plan is
Totally.
having somebody feel heard and safe. So the opposite is also true when
Mhm.
when providers are not listening, when they're not hearing the story and helping. And here's where it's like you have greater medical knowledge, right? We don't want as patients to have to like have an MD to go to the doctor, right? That sounds really like a lot of work. Um, so we want the doctor with their and the medical provider with their vast knowledge to be able to paint the picture, right? But why not paint the most hopeful, empowered, like picture where we like seed in these idea of like making behavioral changes or making changes as like something that you actually believe is possible for that person. And then what you're doing is storytelling, is building this narrative in this way in which they're already successful at doing it,
Yes.
right? And being and offering them kind of why. So we're talking a lot about, so I want to hear more, like let's talk about actually like the nitty-gritty of placebo, of nocebo. I mean, I told my story about that provider. I know as a fat person it happens all the time. People just look at people, providers just look at people and think they know everything about their health.
Yep.
So many conversations I've had with friends and peers and colleagues who are like, I walked into the doctor's office and they told me I should be exercising more, but they didn't know I ran marathons.
Yeah.
So the presumptions,
Hmm.
I think, being able to check one's biases and
Yes.
beliefs about kind of even what health is can be really helpful.
Oh yeah. I think because like really what it is, especially from the clinician point of view, yeah, it's like leaving assumptions at the door. And usually the reason we think we have to have all the presumptions and we need to know everything before we even walk into the room is because we're really conditioned to think we need to have all the answers, we need to fix them immediately, we need to be the expert. So we have to like, study for the exam. And every patient
Mhm.
encounter is basically an exam. And that is really stressful. And so then, say a patient starts talking about multiple fluctuating symptoms in various body parts that wasn't something you learned about in school. Those are patients then that are labeled as difficult because really what's happening is the clinician is having difficulty putting them in the box so they can ace the exam is one way.
Oh,
And honestly, like I think so much of this is rooted in our education system, like med school being the last stop, but like even ahead of it, like who gets into medical school, who gets into residency, and this need to like perform.
mhm.
And it's so stressful for the clinicians. Like that's like people are burning out and they feel mad at their patients and they hate it because like obviously if someone like didn't care about humans at all they would find another career. There are other things to make money doing, right? But there's something at some point they're like, "Oh, I love connecting with people. I love being a part of witnessing them healing or getting better." Like that's so enriching and nourishing. But then something happens when then you tie to if you're a failure or success to if your patient heals, right?
Mhm. So even that is
Tricky.
like, if you think about like as a clinician, what are the nocebo experiences you're having inside the container of practicing medicine?
Oh my God.
Right?
Yes.
So it's like, how can we make this analogy really stick for people?
Mm,
Right? So that sense of pressure, failure, belief that everybody's a test, right? Like, how is that moving you, further away from a sense of wellness?
yes.
And how is that showing up in your medicine practice?
That's
And
it.
like, what
Yeah.
beliefs are being reinforced about
Yes.
your patients?
Mm. And yourself with your patients, which is always what's underneath your patients, but you may not see it, right? So it's like, yeah. So, I mean, common things are like perfectionism, imposter syndrome, like these things, which are these incredibly oppressive belief systems. So, perfectionism, I have to be perfect in like, because that's impossible to define, it just pops up. I have to be perfect in what I say to patients. I have to be perfect in what I communicate. I have to know all the answers, like all the ways it comes. And so
Mhm.
that expectation will, yeah, have a nocebo effect. That's so good. Like it will then make you feel more imperfect in a negative way.
Yeah.
Imposter syndrome, maybe even more so. Like I'm an imposter. My brain's looking for all the ways I'm imposter. So I feel more alone. I feel more disconnected with everyone in medicine. And then, so then that brings on, I guess you could say nocebo effect of being more of an imposter because you're
Yeah.
hiding further. Like that's such a
And
brilliant
it
way to.
brings you not into curiosity where you can find out like where are your patients already succeeding? Where it's like what is the smallest change that they
Yes.
actually need to make? Where
Yes.
are they doing great at?
Yes.
Like where can you help them see, you know what, if we know a lot about like the biological benefit of sleep, right? So it's like, where can we make the greatest impact on people's health that
Mhm,
actually like runs down that domino effect of change, right?
mhm.
So like sleep is a place where, right, if like people's sleep was improved, they would have maybe better blood pressure and
Yeah.
maybe glucose and, like blood glucose and all of these other health factors, right? We know that most illnesses are stress related.
Mhm.
So it's like, yeah, I don't know where I'm going down a different path, but I was just like, what is it that's bringing us into this connection, but also like using nocebo? I think here's where I want to go with this is like, how can we use that these concepts are scientifically proven to be true,
Yes. Yeah.
Nocebo and placebo are real,
Mhm.
and there are entire books written about them. There are many, many research studies that show the power of both.
Yeah.
So they exist. They're not just ideas. So how can we like investigate when we're in practice? Am I using nocebo or placebo? Am I inviting, like, which of these am I using in this treatment plan? And if
Yeah.
it's
So good.
nocebo, like at the very least, how can you remove that from your treatment plan, which is like helping people, taking away the fear that you've been adding in? Because, a lot of like behavioral, what I've noticed traditionally is a lot of like behavioral work is about scaring people,
Yes.
smoking cessation,
Oh, yeah.
right? We're
Unsuccessful.
like, and you know what? You really can. I mean, like as a hypnotist, like you can work on creating aversion to smoking with some very well planted suggestions
Mm,
that will make people change their behavior.
mm.
I talk, but that's using inside a container where you're like helping people bypass their critical factors of their mind on purpose for their benefit because they want to stop smoking.
Yeah, and they've consented and are interested actually to begin with. It would be
Yeah,
the key piece of that.
but
Yeah. I think
there
actually
are,
that,
yeah,
oh
sorry,
no,
you go.
I was thinking, I think a key thing I'm wanting to name is, so like I think it starts with for those who are listening who are clinicians, like examining our beliefs about our the human body's capacity to heal, and noticing where what we've been taught doesn't even like add up. Like, can you think of all the times where patients were supposed to pass away or were supposed to get worse and then they got better, and then we're like, as if the exception, but truly the human body's ability to, like, the human body's designed to heal, and then at some point for all of us, the design does break down and death comes to us all. But like along that way, like it's just constantly trying to heal itself. So like, can we shift our own beliefs about our bodies and other bodies that they are oriented to healing, and believe in the possibility, always have that possibility open ourselves. And then I'm thinking meeting the patients where their belief system is at, because I can
Mhm.
imagine someone listening to our conversation and now being like sort of trying to do like a toxic positivity pitch of like,
Yeah.
you just got to believe, and like that's not what we're talking about.
No, yeah.
But it is
Almost
getting curious about like, what are your beliefs? Because I know a lot of my patients' beliefs are this won't get better, and so then
right.
it's like, tell me where it has improved, or tell me the gains you have made, and then starting to shift their belief. Like that's actually really, having coaching training now, I feel like that's enriched those conversations with my patients so much, of like how you help shift a belief, you know?
Well, because if you didn't know that you had power to
Mhm.
help somebody shift their belief, if you asked a question like, what do you believe about your chances? And they're just like, one, they're just looking at you probably like, I don't know. Like, aren't you supposed to tell me what that is?
Yeah.
And then the other part is like, if they are in low belief about their ability to heal because they don't understand that the human body is really designed to heal,
Yeah.
right? Sometimes it's like, how do we take away the obstacles? Like, how do we increase kind of the factors, how do we decrease that allostatic load, right? How do we decrease the factors that interrupt healing?
Mm.
But if they don't know that, because how would they know that? Because the human body is often just kind of not talked about that way.
No.
But as the clinician, if you didn't think that you had the ability to influence their belief and raise their belief in their own healing and kind of like encourage them, then you wouldn't even want to ask that question. Because, like, then if you get this answer, like, well, I don't really think anything's going to help,
Mhm.
then your answer is like, oh, well, like, then you're kind of stuck. You're just like,
Well, listen, at least
Well,
you
me,
still got some
you'd
information.
be like, me either.
We're in this
Good,
together,
nice knowing
right?
you. Yeah. So for
Yeah.
you, like, how would you, what would be different, or like, since learning this,
Mhm.
what's been different for you in terms of like how you relay information to a patient?
I think I have a lot less pressure to deliver the script. I have a lot
Mhm.
less pressure to make sure they hear me about
Mhm.
anything, just because I know how often, even if you say all the words, someone, if they're not interested, if you haven't like really checked what their motivations, what's brought them in, like
Mhm.
you're just snoopy grown-ups anyway, like the want, want,
Mhm.
want, right? And it's made my job a lot simpler. I don't have pressure to pass the test. So I really focus on what they came in for, what
Mhm.
they want, what they're worried about, what their belief systems are. This is
Mhm.
me taking the history. Actually, this is stuff that we're tested on and trained to do. So at least primary care clinicians, like
Mhm.
there's this acronym about feelings and ideas and function that's like really rich, but we think of it as like
Mhm.
this afterthought. But it's my first thing I do now. I'm like, what are your expectations? What do you think is possible? Like I spend probably the most time that, as well as like, which part of the body, la la la. And I think that that kind of history taking is the most therapeutic thing I do, just the listening and
Mhm.
believing. I no longer so many of us feel like we have to decide whether we believe the patient or not. We have to
Mhm.
decide if it's real or in their head, which is nothing. As we know, those are all the same. What are we talking about? But there's all these like inhuman stories we're told. So just sitting
Mhm.
in the belief and understanding the experience of the patient. And then through that, I kind of then, well, I get my hypothesis of what one or several things could be happening in the body.
Mhm.
I
Yeah.
share that with the patient. And also get their ideas about what they think it could be going on, and we kind of collaborate on what options we think could be happening. And then I ask like what questions they have. So some patients are very nervous about side effects and they
Mhm.
want to know, say that we've kind of got to the point where it's like, you know what,
Yeah.
I think this is an infection that likely an antibiotic would help. And then they
Mhm.
have questions about that. So
Yeah.
yeah, then so I definitely don't. I'm like, will I ever use like fear tactics? No. Have I really done this work yet? I think I probably just like many people are, I usually say it like many people have no side effects because that's
Mhm.
unless it's not
Yeah.
true.
Right.
But
But I love that you start with that, right? Because
yes.
it's like many people, which
Yeah.
includes you,
Yeah.
have no side effects.
Yes.
And then because you do want people to not miss something, right? Like if
Yeah.
they have a high fever, you don't want to be like, oh, it's not a big deal. No, it's like, and
Yes.
then I'm sure you're like, and then these are the things that we ask people to look for or something. I
Yeah,
don't know. You tell me like
exactly.
how you would say
Yeah,
that.
I don't even I'm like, don't say like look for things, which I don't know, like it
Yeah.
depends.
No, no,
Like
no, totally.
they're looking. It's like then I was like some people say it's an antibiotic. Some people get diarrhea or stomach upset,
Mhm.
say it's like in very rare cases, these very random specific, like there's some where it's like got a random
Mhm.
specific thing. And I'll say rare,
Mm.
random, you'll know right away. And then I probably
Mhm.
circle back to the many people who are fine. I want to like hold space for all of it. And
Mhm.
then I make sure they know to who to contact so they know there's support if any of them happen. So they're like not
Right.
doing it alone. Like I think that's
Yeah.
how I try and say it in a like a non fear
Mhm.
tactic way. If I've worked
Mhm.
with someone for a while and if I've named in the room and they agree that they have illness anxiety, like they
Yeah.
have anticipatory anxiety about
Mhm.
medicines, I
Yeah.
have a what do you think about not reading the side effect list? Of course you can.
Mhm.
I'm not telling you not to, but what do you think about that as a strategy to support yourself?
Yes.
But I would only do that if I knew they were really motivated. Like I can think of a patient who tried lots of different medicines for this one condition for a long time and then would stop very quickly for who knows, for
Right.
effects.
Mhm.
There's not real versus nocebo anyway, but they felt
Right.
effects and it
Uh-huh.
scared them. But they were really motivated. So we like made a plan that supported the fact that we are aware they had this belief, you know?
Yeah,
So it's kind of, it's like
totally.
that. I don't have like a quick acronym of how to do
Well, yeah, I think there's not, right?
it. Yeah.
It's like, but what I'm hearing you say is we, meaning you and the other people in the room, like are beginning to understand that belief is also a part of the experience of taking a medication.
Yeah.
So, and it's like, I had a client who, one of the things that I do in pain recovery is like we just witness the embodied experience, the somatic experience. And she was very worried about, like, she did not like the side effects of this one medication. And I am not a clinician. Like, I cannot say take or don't take a
Yeah.
medication. And I was like, well, what if you just observed the side effect the same way that you observed the initial complaint? And she
Mm,
was like, what? You could do that? And I was like, well, it's an embodied experience. So it still exists on a continuum.
yeah.
And it's like when we're reactive to the experience that we're having, we make it bigger, more important, louder, like more urgent. And like what we noticed was the side effects went down.
Mm, cool.
And I was like, well, that's cool because I am not in a place to tell you to take or not take medication. But like if we turn the side effects down, then you have a lot more, like, then you'll feel differently about taking the medication.
Hmm.
So it's just like, but that belief that you even can influence your experience of a side effect, like she didn't know that until I introduced that idea to her.
Hmm.
And so it's like, yeah, it's subtle, nuanced. And I love this like way that we can talk about expectation, belief. Some people are open to learning it. Like in my work, when I teach, I use the science of this to help people be like, belief's not just a thing we feel, it's like a whole concept,
Yeah.
which is neat. I don't know
So
that,
good.
like, as a doctor, that's what you geek out with your patients with. I'm sure those conversations are probably super different, but
It really depends. Like it was a patient who first taught me about Curable, which is an app
Mhm.
that kind of uses these concepts for pain
Yeah.
management and like works on pain modulation sort of through belief or and all and other modalities similar.
Mhm.
So like I mean it's just obviously I have a diverse group of humans that I have the privilege of caring for, and so it's such a relief to know I'm not trying to deliver the same care to all of them because I never could anyway.
Yeah.
And so it's less pressure and work for me to think I've got to perform to an external standard, and then I can literally meet each person where they're at, and then I'm aware of my influence in the room. I think that's what this
Mhm.
conversation's bringing up for me.
Yeah.
Not that I have to then give pressure to relieve it. Like if someone has a strong, say, nocebo belief prior to me, they have a real belief about something never working for them.
Mhm.
Well, first of all, is I would probably look for other options that
Mhm.
they have a higher belief in, even if it's actually fifth line, like it's more atypical. It's not what most
Mhm.
doctors prescribe first. But if they're like, listen, I'm open to this thing and I know it's on the possibility and they have a higher belief in it,
Yeah.
hello. Like it's something that a lot of us intuitively do, but it's just nice to be like, look, science, this is like
Yeah.
compounding the treatment. Also, they're more
Absolutely.
likely to do it. So
I
that's,
love that. Like, I love how you labeled that compounding the treatment.
yeah,
That's neat.
I like that term too.
Yeah.
So good. Okay, I
What
think
would, are we done? Yes. Sorry. I
yes.
was like, it's fine. We'll have another conversation another time. Maybe I will have you on my podcast and we can, although we're using this for both of our podcasts, talk
Mhm.
about empowering patients
Oh,
in
yes.
conversations with their providers.
No, we definitely have to have that conversation. I think
Great.
that's really
That'll be the flip
important.
side.
I think that's so good because I mean, hopefully, if folks are listening and they're living the patient experience,
Mhm.
it's not any person's job to, I guess, excuse the behavior of clinicians behaving badly. Sometimes we get a sense when we're the patient, you're like, oh, this person is putting something on me. So hopefully you at least feel validated. Yeah, it's not you. It's definitely the clinician and
Mm-hmm.
their baggage. That doesn't make it okay. But sometimes it's useful to know that. So hopefully this conversation's been
Yeah,
helpful from that perspective. And then
totally.
then like, as the patient where there is an imbalance of power,
Mm-hmm.
how can you then? I would love that. So we
Yeah.
need
So I think we're just gonna stick a pin in that and be like, we are gonna have that conversation because
yep.
I know when I walk into a provider's room, knowing that they're gonna look at me and make a bunch of assumptions, that I can be proactive and and like be more of a cultivator of the experience that I want to be having. And even when I have a negative one, like knowing, okay, at the very least, what is it that I'm trying to achieve here? And how
Yes.
can I be more likely to get it, even if I have to sacrifice the relationship?
So good. Yep.
Yeah. So
I love
that's a
that.
little teaser. Um,
Teaser.
I love talking to you. I love your
You.
curiosity. I love how you are changing the world of medicine. And I feel so honored and grateful to like get to have these conversations with you. So thank you.
Thank you. I mean, it was like your webinar and then working with you. I know you draw from many influences, but your synthesis of them and working with you, it was like seriously life changing and practice changing about how I even think of my own body for sure. And I think of my patient's pain. So thank you to you, Deb.
You are so welcome. And then like people should just go Google these words because they're fun
Yes.
and follow your interest to learn more.
Yeah, I think I'm gonna post the link. I'll put in like my show notes, like the link to
Yeah,
the nocebo video, because
great.
it had some more examples than we even gave here.
Mhm.
Um, yeah. Okay.
Cool.
Thank
Awesome.
you.
Thank you.